patients have to trust us enough to be able to share some pretty intimate details about their life. Sometimes for an individual to say that they don't have access to food, that can be something that they're worried that is going to cause a lot of stigma or implicit bias. And so I think we have to be really thoughtful about how we ask those questions and then what we do with the data. Because I think there's already a distrust, in particular for marginalized communities, there's a distrust of the healthcare system.
Hello, this is the Meeting the Minds podcast by Robot Health. We are live at Health 2023, and I'm Chris Hemphill, your host. I am excited to welcome Dr. Roshni Koli to the show today. Dr. Koli started in psychiatry, and she is now the Chief Medical Officer at the Meadows Mental Health Policy Institute, overseeing all medically focused policy and practice guidance. Today, we're going to discuss her journey from practice to policy leadership and the need to look even deeper than common social determinants of health within mental health care. But before we start, Dr. Koli, would you like to share a bit of background on Meadows, just for the listeners that aren't aware of the Institute and its work?
Sure. Thanks so much for the opportunity to be here, Chris.
Thank you.
I'm really looking forward to our conversation. So for those who don't know, the Meadows Mental Health Policy Institute is a nonpartisan, data-driven organization that focuses on the intersection of policy guidance and program implementation. And the mission really is to provide equitable access to healthcare for all who need it within Texas, the nation, and the world.
From hearing your perspectives on that work, it makes me really excited to dig into that work and share that with our audience. Would you care to share your personal background and what's led you down this path in general, not just from the job focus, but just from your background and personal focus?
Absolutely. So my journey into healthcare started from a pretty young age. I was born and raised in Hawaii. My parents are immigrants from India. We really were in this kind of multicultural place in Hawaii, and pretty early on, when I was about 11 or 12, we took a trip to India, and I was with my mom, and we had this opportunity to really see kids who were struggling with even just meeting basic needs. And we had some really honest and hard conversations about that. And it was this recognition that everybody doesn't have access to the same things, and that there is, I don't know if duty is the right word, or almost like an obligation that we had a value within our family is to help, to do good when we can, and to be able to help in whatever way we can. And so that was really where that start came from, where I really thought about, I think going into medicine is really what I want to do. My mom was a pretty incredible woman. She had the ability to see the best in people, and she was one of those individuals that just selflessly loved what she instilled by not really saying that we were better than everybody else, but that if with hard work and dedication and putting your heart into something, there's no limit to what we can achieve. And at the ground of that was always helping people. That dream was really instilled pretty early on, but I lost my mom when I was 17. And she died pretty quickly, within a couple of months after being diagnosed with an illness. And that really rocked my world, experiencing that type of grief and loss from an individual who still continues to be my greatest inspiration every day. And so I had, at that point, struggled a little bit academically. I didn't have the most linear journey to get into medical school, but got there. And when I was in my clinical rotations in the middle of New York, I realized that my ability, my superpower, I think everybody has superpowers, mine was to connect with people. And I really loved being able to talk with an individual, hear their story, figure out how I can help, and be able to really actively listen. When I went into medical school, my father is a general adult psychiatrist, and I was like, I'll be any other kind of doctor, but I'm not gonna be a psychiatrist. That's my dad's thing. I'm my own person. I thought I'd be going to school and be a pediatrician. I've always loved working with kids, loved babysitting, have loved spending time with kids as a camp counselor, all kinds of other stuff. But when I got into my clinical rotations, I realized, connecting with people and hearing their story and figuring out how biology and medicine and the art of human connection all come together, psychiatry is actually a really good place to do that. So figured out that what was my own was really going into child psychiatry, because I feel like with kids we have this really unique opportunity before we're adults and we're sort of molded, we're kind of set in our ways, if you will. But as a child, you have this ability, even if they have struggled, if they're struggling in a place, we have this really wonderful ability to change their entire trajectory. So I feel like there's so much hope in being able to look at childhood intervention. And ultimately, mental illness is a pediatric illness. Half of all cases manifest before the age of 14 and 75% before the age of 24. And yet it takes 8 to 10 years on average before children receive the type of treatment that they really need. So much of what we experience in our childhood shape who we are and who we become and what types of illnesses manifest. And sometimes I think I've asked a lot of my patients, even my adult patients, and I've asked, when do you first remember experiencing something like anxiety? And many of them will say that they remember very early childhood. And as we get through, what are those symptoms look like? What did it feel like? They can really remember all of these things in early childhood that initially manifested, even if they didn't get help until much later in life.
Could you go into the transition from like understanding like psychiatry is my place to like then becoming medical director and leading those efforts, and now going to a more global perspective with the policy impact? Would you mind talking about that journey?
Sure. I think it's been a very non-linear journey. I don't think I ever imagined myself to be a healthcare leader. When I started practicing clinically, I was fortunate enough to start my clinical practice after residency and fellowship in Hawaii, which is where I'm from, and work at a women and children's hospital. And I had this goal of really wanting to be in a children's hospital, and in residency I really focused on helping women and postpartum women in particular. And so had this unique opportunity to be able to practice at the hospital that I was born at, and practice with some of my original pediatricians as well, which was such a cool experience.
Yeah.
And part of it was also my focus was just to be the best doctor I could possibly be, to be able to understand and to know that there's so much that I still don't know, but that to really be able to learn the clinical art of medicine, I was going to need to see lots of patients and be humble and build my knowledge and build my skill set. And so that really was my focus, is how can I be the best doctor that I can possibly be? And then about a year after I had started practicing, my boss at the time became the chair of psychiatry, and I was put into this leadership role to lead our behavioral health team at the Women and Children's Hospital.
Wow.
And it was initially a pretty small team, but we were able to really get some traction for that entire healthcare system to think about behavioral health and mental health differently, to really say that, listen, this sort of aspect of how mental health affects all dimensions of physical health and vice versa, that's something that they were ready to see. And so we had this opportunity to really think about building in mental health aspects to all different aspects of pediatric and maternal medicine, and then have our team grow.
Was it an easy decision when like you're focused on being the best psychiatrist and now you're asked to lead? Was that an easy or difficult decision? How did that go?
I don't know it was something that I necessarily felt ready for, but I think it was something that, I think sometimes when we sort of sit down and kind of listen to that quiet voice, it was, let's show up. I don't know what this is going to hold, but let's give it a try and see what happens. And I found that I really loved it. I loved leading. I loved being part of committees and groups to kind of think about things at a larger level. I think that strategy and vision felt like a very natural progression of who I am as a human being and what I wanted to contribute in medicine. And then the mentorship part, I got to see some trainees become attendings, and some that I even hired or started to give people their first jobs and to mentor them into medicine, but also just being able to relate to individuals as being human. And then having kids, I think having children is one of the most humbling experiences ever. But, having children, it was really always important to me that we created a place at work where children were welcome and that we understood the importance of flexibility. And so as a healthcare leader, I've had the opportunity to do that, to create that culture of saying that, I can't always take away all the stress of medicine and practicing clinically. But wherever we can offer care and support and we can create flexibility, especially for moms and dads of young kids, I've had that ability to do that, and that was really meaningful.
This most recent move, we're going from leadership at individual institutions to making the policy recommendations and making those practice and policy recommendations that affect a broad community. Can you talk about that transition and what brought you here and maybe like what some of the limits that you might have been experiencing were before you made this transition into Meadows?
Definitely. So for the last 5 years, I've had the privilege of practicing in Texas at Dell Children's Medical Center and Dell Medical School. And in that, it was at a very unique time where there was a huge amount of mental health funding through policy initiatives that allowed us to grow programs that were innovative and thoughtful, whether it was school-based telehealth or it was providing consultation for pediatricians. But they were programs that I saw tangible results with, that we really saw increased access. But at the same time, there's also limitations. And I realized that to really think more broadly, to reimagine a healthcare system in which mental health and physical health are really looked at one and the same, that it's just looked at as health, which has always been my vision when thinking about things in a children's hospital. I realized that to really be successful with that, we needed to be able to make some changes on the policy front, needed to be able to move some levers on the policy front to really ensure equitable access and looking at mental and physical health as one and the same. That in that setting, I saw what we could do from direct clinical service to leadership and being able to impact more lives through the programs and infrastructure we're creating. And then also saw the limitations that when we don't have an infrastructure yet, although I think we're starting to gain some recognition, but we still don't have an infrastructure that really views mental and physical health as the same.
Truth.
Right. And so if we wanted to do that, I felt like this change would be at the policy level. And that was kind of what led to that journey. So my why has always been the same. It's how do we impact children and families' lives in the best possible way, ensuring that there's no difference between mental and physical health. But to get there, I think as I've experienced more things within the healthcare system, it was policy oftentimes doesn't have a clinical voice. And so for the Meadows Institute, I'm their first chief medical officer. That wasn't something that they have had previously, but have always valued clinical input. And so this job was a really wonderful opportunity to be able to think outside of the box and to think about how can we lend clinical guidance and expertise into policy recommendations. What a cool place to be. Meadows Institute has been hugely instrumental within the state of Texas in ensuring that we've had a huge increase in funding for mental health within the state. But then to be able to do that with really thinking about what's the best evidence base? What does our clinical expertise tell us? What are also the factors that are leading to workforce shortage, including things like clinical burnout? What are the things about our system that make it so challenging to practice? And can we kind of infuse some of that in those policy recommendations?
You're hitting my heart with every word here. A lot of the problems that we talk about, where like, the inputting information into an EMR, for example, is extremely burdensome. But then there becomes a question of like what is the underlying reason that this information even has to be placed there?
So I think what we're sort of talking about is that sense of community, right? How do we kind of each kind of look at the greater good and not just sort of what's happening in our own individual world?
Exactly, and so there's kind of a feedback loop that I want to explore with that. What are some of the limitations that you see?
I think we've come to this as a society because we've starting to really recognize that not everybody has equal access to opportunities. And so not everyone has equal access to opportunities for care, for education, to even be able to care for themselves in the way that they want to. But that we think about things like housing and food insecurity. We think about education sometimes too, but sometimes there's these other aspects of what it is surrounds an individual in terms of their environment, what created their sense of being, what their home life looks like. Those things aren't always captured in some of these tools. But there's also some limitations of gathering this data. One of the things that I found in clinical practice is that we first have to establish a place of trust. And patients have to trust us enough to be able to share some pretty intimate details about their life. Sometimes for an individual to say that they don't have access to food, that can be something that that they're worried that is going to cause a lot of stigma or implicit bias with that. What does that mean? What is the doctor going to think of them? What is the social worker going to think of them? And so I think we have to be really thoughtful about how we ask those questions and then what we do with the data. Because I think there's already a distrust, in particular for marginalized communities, there's a distrust of the healthcare system. And so how do we earn their trust by doing right with that data? By keeping those things private, but also recognizing what we need in terms of helping to understand what contributes to quality and outcomes of care.
That distrust is honestly quantifiable. Because you started by talking about data itself and the overall limitations of it, and that's one thing I hope people really hear that message, is to not be mired into taking what's endorsed in data sets or like what's captured in EMR as the absolute truth. And a lot of times, rightfully so, a lot of people feel that data that they report back might be used against them in some way, and their honesty might result in their harm. And the quantifiable element is like, if you're at a hospital and you look at your EMR data right now, you're not going to see you're not going to see 100% response to the ethnicity question. There's a possibility that you're not even collecting data on the gender spectrum or sexual orientation in a way that captures the full breadth of it. So there's all kinds of limitations that we need to be more open about.
Yeah, I couldn't agree with you more. I mean, there really are limitations to the way that we ask those questions and how we capture that data. You know, another example is, and I see this frequently in our EMRs, is that sometimes diagnoses don't get taken away. You know, they don't get removed. And so, for instance, an individual could have received a diagnosis, say, of schizophrenia, but now we know several years later that that diagnosis actually isn't accurate. Maybe we think they have a depressive disorder that had some psychotic symptoms in a severe episode. Sometimes that initial diagnosis doesn't get removed, and so there's still these multiple diagnoses on the chart. And so that's another example about how data isn't always correct. And you know, we have to be really thoughtful about how we're really using our EMR and electronic database to be able to say, is it really capturing what an individual is experiencing?
Yeah, one thing I like to tell people to do is recontextualize what data actually is. Like, if there is information on an encounter, for example, it's not an ICD-10 code. It's not a series of codes. It's someone literally trying to go in and better their lives in some certain way. If you think about it from that perspective, then what was going on in their life at the time? How were they doing? How was their family doing? All these different factors are things that impacted that visit that didn't necessarily get captured in the database.
That's right. Yeah. Yeah. And you know, and sometimes I think there's also, again, some of the kind of mental health notes and the information that we gather, more often than not, families are comfortable with me giving their pediatrician a call and saying, listen, I want to share information so that we can coordinate care effectively. And your primary care physician is really the individual that is at the center of our healthcare system. But you know, sometimes they don't want their pediatrician, or they don't want their school to know that they're experiencing depression or anxiety. Sometimes, you know, I think for families still, there can be a stigma that's associated with a mental health diagnosis. And so I think we need to break down some of that stigma, but we also need to respect a patient's confidentiality and be really thoughtful about how we share information.
We're establishing this sphere of just mental models to understand like the limitations of social determinants of health data and approaches. Another part of me wonders about, like, we talk at the grand visionary level a lot of the time, but there are nurses and other people that have to collect this information, and there's a big burden in terms of there's so much that's being collected. I wonder, does asking for more data points, does it pose a potential operational challenge, and what are some of the ideas to navigate around that and still ensure the accurate collection of data?
I think it definitely does. You know, I think about, for instance, for a mental health intake or kind of a diagnostic evaluation, there is so much information that I as a psychiatrist may want to gather and know from my patient and family and pediatrician and school. But say that some of those questions about where they were born and who they live with and what school they go to, maybe that's captured in the social worker's note. Maybe there's already some data that the nurses gathered about their medication history. One of the things that we can do in clinically to be able to reduce some of that, and if we go and ask that patient for a second time or a third time to tell their story or the same questions, sometimes that can feel really exhausting for patients. And so I think part of that is one of the things that we can do and that I oftentimes really try to practice is look at the notes that came before I'm going in to see a patient, and then also recognize, I always acknowledge, especially with my adolescents, Mick, I know you probably told your story a couple of times already by the time I'm seeing you. And they're like, yeah, we gotta have, but I think just acknowledging that, yes, I'm asking you to repeat some of these things, but it's really important for me to hear in your words what brought you to this time and this place so that I know how I can help. But I don't have to repeat some of the same questions. I don't need to ask them where they went to school if that note and the information is already there. Right, and so I think we can be really thoughtful about which questions we do need to ask again to understand and which questions we can gather, and we can really be thoughtful about how we as a healthcare system approach the information that we need for medical decision making.
So we've talked about the overall limitations of data itself and some ways to address the operational issues. So when it comes to a smart strategy around social determinants of health, or when it comes to something that you've seen perhaps that has been enacted and driven some successful results, do you have some examples of this overall data collection process and intervention process kind of working really, really tightly in lockstep?
I think one of the things is to make sure that we're not duplicating efforts. So if there is one member of the healthcare team that is asking about social determinants, to make sure that when they're documenting that's easily accessible to the rest of the healthcare team. So we're not asking the same questions every time we go into the room. I think that's one aspect. The other is, what do we do with that data? What are we doing with that data? And I think really to preserve that trust with our patients and with individuals who are seeking out care, I think it's really important to be upfront about why we're gathering the data. Right? So if we're asking about social determinants, I think it's important to have that conversation first, that the reason that we're asking about this, because we know that there's other things that affect your health other than what your labs or your x-ray or may show me. And so that, I think, is also kind of creating that space, and to also ensure that information is only shared with the individuals it needs to be shared with, and that it isn't that we're doing things within our healthcare system to be able to be thoughtful about privacy.
Great. So a lot of it is, we're talking about a lot of operational issues, but we're also talking about earning the right to ask those questions.
That's right.
If there are constant data leaks and cybersecurity issues, or if there are, if that data contributes to bias in other parts of the health system, then you honestly haven't earned the right to have that relationship with the patient.
That's right. And I think the other aspect that I'd add to that is that, we all have implicit bias, right? We all see the world the way that we see the world, and sometimes we're not even aware of what implicit bias that's there. So I think one of the things that I also think about from a clinical perspective is, can I reflect on my own implicit bias? Did I have a thought about a patient before I entered that room and that space? Or what is my thought afterwards? And so to always recognize that we're all human. There are going to be things that we miss, but how can we reflect and remediate within that?
So I'd like to get even more into practice, and I'm not sure if you might have been involved in this project, but there was recently a program launched to train primary care pediatricians on addressing mild to moderate behavioral health issues. I wonder if you could share some background on that, and if that kind of relates to our views on social determinants of health and other helpful aspects of bringing in this whole person care focus that we were talking about earlier.
definitely. I think what you're referring to is our collaborative care model, and really thinking about, and I think what the vision behind that is the pediatrician or family medicine physician, the person who's known the child for the greatest amount of time, oftentimes since birth. They are oftentimes the person who a family will turn to if there's a mental health concern. So just like they would if there was a broken ankle or a strep throat, the first person that I'm going to call as a mom for any type of concern for my child is their pediatrician. And so if we can empower the pediatrician to have the knowledge and the skill set and the information to be able to treat mild to moderate mental health conditions, we are reducing the stigma of mental health. We are providing services where a child and family is already presenting rather than thinking about fragmented care. And we're saving our workforce, our child psychiatrists, our pediatric psychologists, our therapists, for individuals that really need that level of care. Because we know that we have such a big workforce shortage that really what collaborative care is and primary care integration for mental health care is it really means that we are focusing as much of mental health care as we can within that physical health care setting. We're really looking at whole person care.
So, and your involvement, I would imagine, because it's around policy recommendation and practice recommendation, that could probably help with conducting this training and creating this training in a way that's not overly burdensome to an already overly burdened group of physicians.
100%. I mean, I think that's really the goal. And I think when it comes down to it, there's a couple of different innovative models that help us to leverage kind of the workforce, if you will. The other one is CPAN or CPATH, access lines in which pediatricians or family medicine physicians can call, usually a warm line that is run by the state, and then they can get access to a child psychiatrist within 30 minutes and get recommendations on diagnosis, evaluation, assessment tools, medication, and referrals. And so that is also something that can be really helpful. Collaborative care is an evidence-based model in which you actually embed this behavioral health care manager into the primary care physician's office. And you can do measurement-informed care. So we're doing validated assessment tools that we're tracking over time to see if the treatment we're providing is actually effective. So, it's not a one-size-fits-all, and I think it's really important that at the heart of it, this is about establishing a really strong relationship with our primary care colleagues, about them feeling like me as a child psychiatrist or our psychiatry workforce, we are there to empower them, to support them, to help them, and those programs are only going to be as effective as the strength of those relationships.
Excellent. Well, yeah, and that is a very empowering position to be in, especially when we know that it can initially look like something that is an initial burden, additional training and things like that. But when it comes to, what is it, about 75% of mental health cases are identified in the primary care setting. Yeah. And for people that want to practice at the top of their license, it opens an opportunity, right?
That's right. And oftentimes pediatricians are telling me that they're already seeing all of these cases within their primary care setting. They're already, kids and adolescents are already coming with mental health concerns. And so it is an additional burden to have to kind of think about a different level of training, to think about more, but if we can give them the tools to do it in as easy a way as possible, it actually does overall improve their quality of work life. And oftentimes the most frustrating thing as a physician is that if a patient comes in and I don't have what the patient needs to be able to help them. And so I think, so similar to that, if we think about it in that sense, if we're giving pediatricians the tools to be able to empower them to feel more capable, to be able to help with that patient's needs, that's a win for everyone.
I want to draw an intersection. I want to kind of make it a little bit of a circular conversation, in that we were talking about social determinants of health from a data perspective. Do you see the data that's collected from SDOH perspective and other data? Do you see this helping with this feedback loop of being able to through any kind of digital health ecosystem or platform? Does this feedback into the ability to help clinicians have an option for their patients in these scenarios?
I think we're moving in that direction, and I think that's really where we can leverage AI and really digital health to be able to have all of that information. Our EMR system, our electronic health system, is still very fragmented, and I think that that is really the area that we need to go, that we need to ensure that, if we do a social determinants of health screener in an emergency room, that the pediatrician can see that the specialist can see that, the child psychiatrist or pediatric psychologist, and so that we're not asking those same questions. But one of the challenges is that we have so many different electronic health records. We don't have a shared data platform oftentimes in which all of an individual's care providers are seeing the same information. And so that's, I think, where we have the greatest opportunity for growth. Really thinking about that. How do we share that information in a thoughtful way?
It digs into one of those tough questions because a lot of the time it's not necessarily a limitation of the technology being available to be able to share information between systems. It's about the relationships that systems have with each other and their permissiveness in establishing these data partnerships. So it leads to a question on the role that leaders at these institutions can play, that healthcare executives can play in creating an environment where the data can be shared, or patient access, or patient access and history and things like that can be executed with a shared vision across these multiple institutions. I just wonder if part of the policy recommendations call for healthcare leaders to collaborate across their own departments and across company lines.
That's a wonderful question. I think some of the things that we've really looked at in those policy recommendations is how do we account for the fact that when you are seeing a child as a primary care physician, you have so many different stakeholders. So they may have a pediatric mental health specialist, they may have a school counselor. There's oftentimes more coordination of care that needs to exist. And so I think what we can look at in terms of that collaborative care model, really looking at the type of reimbursement so that those models can be fiscally sustainable. And so that is a really big aspect of that. If we're asking primary care physicians to do more, we want to ensure that to do more has a value add. We know it has a value add in terms of clinical care. Can it also be fiscally sustainable? Are we looking just as much into social determinants and mental health care as we are into someone who has a broken ankle or someone who has strep throat? Making sure that we're really kind of thinking about all of those things as one and the same, and that there is a fiscal sustainability within those systems to do that. So that part is definitely there. I think from a healthcare leadership standpoint, I think that there's more that we can do to sort of all play in the sandbox together, right? We oftentimes have different competing health systems that are on different electronic medical records. Are there some things from an operational standpoint that we can do to establish workflows that encourages and really automates coordination of care? So for instance, if a child is at the hospital and say they were on an inpatient mental health unit, does the pediatrician get a discharge summary? Do they know what medications the child is on, what the follow-up plan is? So there's some things that we can do to sort of automate some coordination of care and make sure that those release of information, that we're talking with patients and families and saying, this is who I'm going to share your information with, and this is why. Because if we do that at the onset, then we kind of can look at the digital solutions and the coordination of care solutions, those automated workflows.
One major point that you brought up was making sure that it's fiscally sustainable. So that would require people coming together to determine what is a model that actually would work. Because we all want to do this. We all want our patients to do better and see better outcomes and things like that. But we have to come to the table and think about ways that we can do things that we haven't done in the past to start addressing these challenges in a new way.
Yeah, and I think looking at, sometimes it's also kind of being really thoughtful and creative with funding. So for some of the pediatric collaborative care pilots that we have looked at, we've really been able to think about combining philanthropic funds with state funds or federal funds. Thinking about what's a one-time expense and what do you need to make a program sustainable in the long run. So really being thoughtful and creative with funding and recognizing what are the true costs of implementing a program, including are we honoring that physician and that clinician's time in learning a new model, right? Not just asking them to do something on top of everything else they're doing, but are we providing them the training, and do they also get some recognition that this is time that they're putting in that they may not directly be seeing patients? Do we have a way in which we're accounting for that to really account for true fiscal sustainability?
Well, this is an extremely powerful conversation, and tell me if I'm wrong, could be very wrong on this, but a theme that I hear repeatedly in what you're saying is, if we're going to ask patients for some kind of information additional to what they're used to giving, they need to understand why and what they get back from it. If we're going to ask physicians to do some additional training or data gathering or something like that, then we also have to have them buy in and help them understand why. And that same thing applies to, even from that leadership perspective, is that there has to be some, we have to think about not just asking people to do things, but how do we build incentive structures to give them the vision to actually pursue it.
That's right, and to understand the why.
Yes.
I think you brought those things together beautifully, and I couldn't agree more.
Well, thank you so much. Thank you so much. Now, we're going to give you a magic power that's so powerful that even Meadows doesn't have access to this power, and it's a magic wand. I don't have a physical magic wand with me on the video, but this magic wand, we ask this of every guest, is if you could change anything, any one thing about the way that healthcare is delivered, what would that be?
I think I would say that we treat mental illness the way that we treat cancer. And so what I mean by that is that years ago, we decided as a society that no child should die of cancer, and we're going to do everything in our power to make sure we have the best research, we have the best infrastructure, we have the best services in place, regardless of an individual's ability to pay. And we have not done the same with mental health. And so I think my magic wand would be to really look at it as this urgent situation in which we are putting all of our resources and ability to change the trajectory, to do more research, to create better infrastructure, to make sure that we value an individual's mental health just as much as we value their heart health and their bone health. And so to really think about that so that our structures really mirror it, so that we're not just saying it, but it actually exists. That we are looking at saving an individual's life from their mental illness is just as powerful as doing an intervention to save a person's life from a heart attack. And we compensate that the same, right? So that is not something that exists in our world right now, but that would be what I would hope for.
Honestly, I couldn't agree with you more in that we're beginning to have those conversations. People are beginning to understand. One thing that bothers me is if somebody says it's just anxiety or it's just depression, as if that's not as equally valid as like some of the things that somebody might be presenting. I'm on board with you on getting away from that particular mindset. Well, it's been such a delight talking to you, and thank you for bringing in your personal story and using that as kind of foundation for all the things that you're focused on and working on today. For the people that are interested in following this journey and seeing that magic wand step by step patiently become a reality, how can people follow you and keep in touch?
Yeah, great question. So through the Meadows Institute, we are actively involved within our community. That is a great place to follow what we're doing within that. I'm passionate about the journey that we are on. And I think, I'm really passionate about human connection. And so I love the opportunity to connect and to talk about shared visions and to gain new perspectives.
Stay the course. I'm super excited about what you and what the Meadows Institute are doing.
Thank you so much, Chris. Thank you again for the opportunity to be here. Really, really enjoy the conversation with you today.
No doubt, appreciate it. Appreciate you being so open with us. And for the folks watching or listening, appreciate you sticking with us for this interview, and hope that you've taken a whole lot that you can apply within your own organization or work. But with that, we will see you next time.